I'm going to be doing a difficult airway assessment, so first thing I'll do is have my patient open up their mouth. I'm going to be checking their Malin potty score. The lower the number, the better. While their mouth is open, I'm going to be checking inner incisor gap. I want a 2 to 3 finger distance, about 4 centimeters maybe, and a smaller gap or longer teeth increases the risk for dental trauma. While their mouth is open, I can have them do the upper lip bite test, and a lack of range of motion concerns me. I can check the thyromental distance. I want it to be about 3 fingers wide or 7 centimeters. Problems start occurring if it's greater than 9 centimeters or less than 6. I can look at their neck girth. A larger neck equals more tissue in the airway, and that impedes my view. I can look at the atlanto-occipital joint movement, and any limitation or pain associated with that is concerning. I'm going to also be asking the patient about any history of difficult intubation, and if they have diabetes, I can also have them do the prayer sign to check for joint glycosylation. If I suspect a difficult airway in my patient, I'm going to grab another set of hands for induction and intubation from another anesthesia provider. I'm going to be thinking about maybe an awake fiberoptic intubation, and with that I'll use nerve blocks to blunt the airway. Reflexes, I can use ketamine to maintain spontaneous respirations, and I can put on a nasal cannula, turn that up to high flow to do apneic oxygenation, and I can grab any video laryngoscopes that I would need. So if I go to mass ventilate my patient, but I can't, I'm going to put in an OPA. If that doesn't work, I can do a chin lift, jaw thrust, two-handed mass ventilation with an assistant. I can ramp them up or put them in a sniffing position. I'll call for help if none of those work, and I'm going to move on to an LMA. I'll throw in an LMA, try to ventilate. If that doesn't work, then I'm going to be thinking about waking up the patient or moving to an emergency, possibly surgical airway. What if I can mass ventilate my patient and I'm not able to yet intubate my patient? I got myself some time. I'm just mass ventilating. Everything's good. I'm pre-oxygenating them. I can think about waking them up, or I can deepen their anesthesia. So I'm just going to turn up my gas, deepen them. I'm gonna make a plan, set myself up for success here. So I'm gonna grab my bougie. I can do a fiberoptic bronchoscope, or I can grab a video laryngoscope, another set of hands, a trach light maybe. So I'm gonna do a fiberoptic bronchoscope. So I'm going to grab my supplies, which is a fiberoptic bronchoscope, an ET tube, some lube to not damage the fiberoptic scope. So here's my scope. I'm going to lube this up. I'm going to extend the bronchoscope, insert into the airway. Turn on my light first. I'm visualizing the vocal cords. And with this, I would have a bite block. Once I seed my vocal cords, I'm going to thread down my tube, remove this bronchoscope, attach my circuit, inflate my cuff. I'm going to give a few respirations, ventilations, and make sure I have end-tidal CO2 on the monitor. My SpO2 is maintaining equal bilateral chest rise and fall. I'm going to auscultate and secure my tube. My next method that I can use is a retrograde wire intubation. So my patient is laying flat. I'm going to gather supplies like a wire from a central line kit, hemostats or McGill's, a tracheal tube, a large bore needle like a 14 to 18 gauge, and a syringe. So I'm going to position my patient, palpate for the cricothyroid membrane. I'm going to clean that site off. I'm going to localize this site if my patient's awake, but they're not. I'm going to take my syringe and needle and insert it in a cephalad direction through the cricothyroid membrane while aspirating for air. Got air there. I'm going to insert my guide wire all the way until I see it in the back of the throat. And then I can remove my needle. I'm going to clamp the distal ends. Use my McGill's or hemostat to grab it out of the mouth. I'm going to thread my endotracheal tube over it. I'm going to insert all the way down until I meet resistance at my wire insertion site. And then I can pull out my wire, inflate my cuff, hook up my circuit, give some ventilations, make sure I got end-tidal SpO2 is maintaining equal bilateral chest rise and fall, and auscultate. Maintain my patient throughout the procedure and secure my tube. Maintain my patient throughout the procedure and document the difficult airway, and let the patient or the patient's family know eventually about the circumstance of their difficult airway so that they can let their future anesthesia providers know.